Hello, I'm Dr. Shalini Arora. I'm the Director of Endocrine Surgery at New York City Health and Hospitals at Kings County, and I have a presentation to share with you today. I wanted to just begin by introducing what endocrine surgery is. After our training in general surgery for 5 years, residents are able to subspecialize in endocrine surgery. It requires an additional training of 1 to 2 years. And our training helps us focus on surgical treatment of endocrine diseases. Specifically, we focus on removal of thyroid, parathyroid, adrenal tumors, and hormonally active pancreatic tumors. The surgeries we perform are both for hormonally active and inactive glands, and the subspecialty focuses on working very closely with endocrinologists. So I wanted to introduce what we can do here at King's for our patients who are referred for evaluation of thyroid nodules. We have in our clinic the ability to do point of care ultrasounds as well as fine needle aspiration biopsies. Many times patients are sent for evaluation of thyroid nodules or goiters, and we do our own ultrasounds even though they have ultrasounds done previously in radiology. Depending on the results of the cytology, which may be either suspicious or indeterminate, there may be results of papillary, follicular, medullary, or other rare types of thyroid cancers that require surgery. These can all be scheduled through the clinic, as well as neck dissections when they are indicated. When we do our ultrasounds, we make sure to look at the lateral neck, and all evaluation is done by us to determine what extent of surgery is needed. One of the most common referrals we get to the clinic are for goiters. Goiters can be treated surgically, whether they are euthyroid or toxic. Also, they may be nodular or they may be homogeneous. Goiters that are enlarging or causing compression are also indicated for surgery. We get a significant number of patients who have retrosternal or intrathoracic extension of their goiters. These are all worked up with imaging, including CT scans ordered by us, and patients are scheduled for surgery after full evaluation. Occasionally, we do remove goiters for cosmesis as well. Another indication for referral to our clinic is patients who are interested in having surgery or being evaluated for surgery due to Graves' disease, or they may have toxic adenomas. Patients who have eye disease from Graves are definitely indicated for surgical evaluation. These patients are sometimes sent through the thyroid clinic or even sometimes through the ophthalmology clinic. Patients who are not able to tolerate medication to either control their Graves' disease or have allergies to medications such as methimazole or propranolol are also indicated for surgical referral. Those patients who don't want radioactive iodine for their treatment or are not candidates, such as patients that have very large goiters or patients that have compression for their goiters, or women who are planning a pregnancy within the next 6 to 12 months should also be referred for surgical evaluation. Patients that have goiters, that have nodules, are usually offered biopsy first, and those patients that have abnormal biopsies that might be suspicious or indeterminate are better candidates for surgery than radioactive iodine. The second most common type of patients for the disease of primary hyperparathyroidism are referred to the clinic. Of course, all patients who are symptomatic from their hyperparathyroidism with bone pain, history of kidney stones, fractures, are all candidates for surgery. But there are many patients who are actually shown to have improvement in symptoms that they didn't even realize were from their primary hyperparathyroidism that report improvement after surgery. Many symptoms are overlooked, such as polyuria, polydipsia. We do an extensive evaluation and make sure they don't have psychiatric symptoms or abdominal pain, or history of things that may be related to their hypercalcemia. Patients who are asymptomatic but have a serum calcium level that's over 1 milligram per deciliter, above the normal range, are also candidates for surgery. Of course, anybody that has concern for malignancy, and these patients usually have extremely high calcium and parathyroid hormone level, are candidates for surgery. Surgery for that is more extensive than just parathyroidectomy, but we offer that at King's as well. Patients are evaluated for bone loss. Also, they're evaluated for renal disease. Patients who have hypercalciuria over 400 milligrams per 24 hours, or history of nephrolithiasis and low GFR less than 60, are also candidate for surgical evaluation. And young patients who develop disease under the age of 50 should also be referred. Secondary hyperparathyroidism, we do get some patients for evaluation with this. Mostly it's caused by combination of vitamin D deficiency, hypocalcemia, and hyperphosphatemia. It's generally treated with medications, with calcimimetics. However, patients that have parathyroid hormone level that is above 800 for over 6 months are they do benefit from surgery, and patients that I have treated with this disease usually are ones that have severe bone pain. They've even had fractures, and they show significant improvement after surgery. Other patients that may be candidate for surgery are patients that have tissue calcification. They also may have persistent hypercalcemia and hyperphosphatemia despite medications. Many patients are not able to tolerate cinacalcet, and those patients are also good candidates for surgery. Parathyroidectomy in patients on dialysis is associated with 15 to 57% greater survival. However, these patients do require longer hospitalization stays after surgery, whereas most of the thyroidectomy and parathyroidectomy patients go home either on the same day or within 23 hours after surgery. These patients end up being in the hospital for a week or two, requiring high levels of calcium repletion, especially if they develop hungry bone syndrome. A lot of it has to do with really how high their PTH level is and how long they've had the bone loss and to what extent. So the earlier they are sent for surgery, as they become candidates for surgery, the less the chance of them developing hungry bone syndrome. We do parathyroid imaging. We do our own point of care ultrasounds in the clinic on all patients with hyperparathyroidism. This also gives us an opportunity to evaluate them for thyroid disease that they may have at the same time. Also, the patients are sent to our radiology department for sestamivi scans. Any patients that's going to have a reoperative surgery is sent for further 3D or 4D imaging as they need it. Biopsies are usually not done for parathyroid disease. That is not recommended because it can seed the tract and is not needed. The surgical planning as far as doing a focused parathyroidectomy versus a 4-gland exploration really depends on what is found during their workup. Most patients who have a preoperatively localized gland with a sestamivi and an ultrasound are able to just have a focused one-sided parathyroidectomy. However, those patients that have multi-gland disease or are not able to be localized or have hyperplasia will require a 4-gland exploration. We also perform intraoperative parathyroid hormone level monitoring during the surgery to make sure that the parathyroid hormone level decreases at the end of the procedure, and that is all done at King's. The adrenal glands referral are less common than the thyroid and parathyroid. However, we do evaluate patients that are found to have adrenal incidentalomas. We do hormonal workup along with our endocrine colleagues to rule patients out for pheochromocytoma, Cushing's disease, as well as aldosteronomas. Patients with large adrenal tumors or multi-hormones are all evaluated for adrenal cancer and treated along if needed with a surgical oncologist. I just listed here some symptoms that patients may have if they have a pheochromocytoma in this chart. We send patients for imaging as they needed. These are all different imaging that is available. They're not all sent for everything, only what is indicated. So they might be evaluated usually with a CT scan, occasionally with an MRI, adrenal vein sampling, especially depending on the disease and if bilateral disease is suspected, PET scans if we think there might be a malignancy. Again, adrenal glands are not recommended for biopsy unless there is a suspicion that patient has metastatic disease from a different tumor to the adrenal gland. Surgeries that we offer are both laparoscopic or open, depending on what the disease is. For most tumors that are not cancer, we offer laparoscopic adrenalectomy. However, adrenocortical cancers are treated with open adrenalectomy, as that is shown to have best outcome. The pancreatic neuroendocrine tumors are rare. The only ones that we usually get are insulinomas. Usually these are benign. We work them up, and depending on location within the pancreas, they can be enucleated. Other tumors of the pancreas, such as gastrinomas and other hormonally active or non-functional tumors, usually require resection of the pancreas itself. And depending on the location, this can be done with the surgical oncologist or just by the endocrine surgery team. The practice that we have is on Friday mornings in E9, which is the same time that the thyroid clinic runs in the same location. So we're able to see patients along with endocrinologists within the same clinic space. We, again, to reiterate, are able to do our own ultrasounds and fine needle aspiration biopsies, and referrals can be placed through the through Epic if you search for endocrinology surgery. Thank you for your attention, and I've included my email address for anyone if you have questions about patients or how to send referrals or any concerns. Thank you.